Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist for more than 3 decades at the Texas Medical Center in Houston, Texas. And today we are going to learn about differential diagnosis of chest pain. When someone presents to the office or to the emergency room with chest pain, we need to be able to make a diagnosis at bedside with history, physical examination, and vital signs. There are a number of conditions that can cause chest pain. Majority of them can arise from the heart, which can be related to the coronary artery disease, and these patients can present with stable angina, unstable angina, or acute myocardial infarction. Similarly, patients can develop pericarditis, that is the inflammation of the sheath that covers the heart, that can also present with chest pain. Pleurisy can also mimic pericarditis. We're going to talk about all these variations. We are going to discuss all these differential diagnoses. While we are talking about heart, we are also going to look at acute aortic dissection. Then moving on to the lung, we're going to talk about pulmonary embolus, pleurisy, and pneumothorax, and we're going to conclude with some of the GI conditions such as acute gallbladder attack, hiatal hernia, GERD, which can mimic cardiac chest pains. So let's start off with stable angina pectoris. What is the characteristics of chest pain that is related to chronic stable angina? Whenever there is reduced oxygen supply to the myocardium with increased demand, it results in chest pain. Now let's talk about stable angina pectoris. Whenever there is reduced myocardial oxygen supply with increasing myocardial oxygen demand, there is development of pain in the precordial region, which is angina. This angina can be felt as a chest tightening, squeezing, pressure, or heaviness, or like stinging, or like a constriction or a burning sensation across the left chest, which is related to exertion, emotional stress, cold, and is usually relieved with rest or nitroglycerin. Sometimes this pain can radiate to the jaw, to the neck, left shoulder, and sometimes to the left arm and abdomen. Sometimes the left arm can go numb, especially the left fifth and the fourth fingers. We may also hear an S4 gallop and sometimes systolic murmur due to papillary muscle dysfunction. This pain usually lasts between 2 and 10 minutes, and as I said, it is usually relieved with rest or nitroglycerin. There is actually no permanent damage to the myocardial tissue in patients with stable angina when they get chest pain. Now let's move on to the next category, which falls also in the acute coronary syndrome, that is the unstable angina. Patients with unstable angina have more advanced coronary artery disease or obstruction, which reduces the oxygen supply to the myocardium with increasing oxygen demand. As a result, there is an oxygen deficit built up so that the patients continue to have pain for a much longer duration. These patients can also experience chest tightness, squeezing, pressure, heaviness, stinging, constriction, burning sensation across the left chest, which is brought on by exertion, emotion, or stress, and it may not be relieved by nitroglycerin. Because the pain lasts anywhere from 15 to 20 minutes. Just like stable angina pain, it can also radiate to the jaw, to the neck, to the left shoulder, or to the fingers. When this pain is associated with elevated cardiac enzymes, we call that as non-Q wave STEMI or NSTEMI. If there is no elevation of cardiac enzymes, we just call this as acute coronary syndrome, and then continue with the workup based on the electrocardiogram and other findings. Myocardial infarction. When someone walks into the emergency room by holding their heart in their hands and just profusely sweating, complaining of crushing chest pain, 10 out of 10, you know you're dealing with an acute cardiovascular emergency. We don't know if it is just myocardial infarction, because a few other conditions can cause similar chest pains we are going to talk about. So this chest pain can last for 30 minutes or several hours or even several days. It is associated with sweating, shortness of breath, weakness, dizziness, nausea, and low blood pressure sometimes. They can also manifest with obvious EKG changes of STEMI along with some arrhythmia. So this is a presentation of an acute myocardial infarction. So any one of these points that I have stressed will be a clue for you in the examination to see that you are dealing with a patient with acute myocardial infarction or STEMI. Because we need to contrast this with other acute emergencies that can happen in the chest, such as aortic dissection or pulmonary embolus, which we are going to talk in a couple of minutes. Okay, let's talk about aortic dissection. Aortic dissection can occur in the proximal portion of the aorta, or it can involve the entire aortic ascending aorta and the aortic arch and the descending thoracic aorta, or it can just involve the descending thoracic aorta or the abdominal aorta. Generally speaking, when we are talking about aortic dissection, the most commonly occurring one is the type 1, which involves the ascending part of the aorta, the arch, and the descending thoracic aorta. And these patients can have a variety of manifestations, and it is very important to pay attention to each and every one of these. Again, these patients present with crushing chest pain, similar to acute myocardial infarction. It will be like 10 out of 10. These patients may also have a history of hypertension, or there may be some signs and symptoms of morphine, which may not be given to you directly, but indirectly they may be referring to morphine's features. This chest pain radiates to the back, an important clue that you are dealing with an aortic dissection, as opposed to a myocardial infarction pain, which usually radiates to the jaw, neck, shoulder, or the arm. The aortic dissection pain generally radiates to the back. But patients with esophageal spasm or acid reflux can also have pain radiating to the back, but that pain is not as severe as the patient who is having an acute aortic dissection. Again, this pain can last for more than 30 minutes or a couple of hours before the patient gets to the medical attention. There are a couple of important things that we need to keep in mind, because they may be used as surrogates to say that you are dealing with an aortic dissection. For example, they may just mention an aortic regurgitation murmur rather than saying this patient had a widening mediastinum on the chest X-ray or the CAT scan. Similarly, they can say this patient had a pericardial tamponade, and you are supposed to deduct that this patient was in fact having an acute chest emergency, and that was aortic dissection. Of course, sometimes when you have a proximal aortic dissection, they may present with a picture similar to STEMI, because it is occluding the coronary arteries. So it can present in a variety of ways, but they're not going to directly give you a question that chest pain radiating to the back, this is aortic dissection, but they may give you indirect evidence of pericardial effuse tamponade, aortic dissection presenting as acute myocardial infarction. So you need to have a broad thinking mind when you are taking your examination to put the pieces of the puzzle together. Like I told you about morphines, they may give one rare, like they may talk about the genetic abnormalities that you see in patients with morphines, or the collagen tissue abnormalities that you see in collagen as one of the features in the presentation, and there you are supposed to deduct that you are dealing with a patient with the Morphin's syndrome. So maybe that may be the clue for this patient having an aortic dissection, especially if you are dealing with a much younger person. Pericarditis. Let's talk about the pericardium. Pericardium is a real thin sheet which covers the heart. We have the visceral pericardium, which is plastered to the entire heart. Then we have the parietal pericardium, which is on top of that. And in between these two, there's a thin layer of a fluid no more than 30 to 50 ml. When the pericardium gets inflamed, it can also irritate the myocardium, and sometimes we can see elevation of the cardiac enzymes. When the pericardium gets inflamed, most often due to a viral infection, it also produces chest pain, which is very similar to pleuritic chest pain. It is sharp, stabbing in nature. Maybe feel like a knife going through your chest, and it can last for hours or days. This pain is aggravated by deep breathing, by movement, or lying down. But if you lean forward, the pain gets better. While the patient is leaning forward, if you listen with a stethoscope, you may be able to hear a pericardial friction rub. So these are some of the features that will point towards the diagnosis of pericarditis. So if you see in the history the patient presenting with vague pain, aggravated by lying down, relieved by leaning forward. So these are the tips. Which tell you that you're dealing with pericarditis. Pulmonary embolism. Just like aortic dissection, acute STEMI, pulmonary embolus is an acute thoracic emergency. Here is an example of a CAT scan showing blood clots in both main pulmonary arteries. We are talking about large blood clots. When patients have this type of pulmonary embolus, they're going to present with an acute chest pain, which is similar to the chest pain that patients with myocardial infarction or aortic dissection present. The chest pain sometimes could be pleuritic because sometimes they can have pulmonary infarction and some degree of reactive pleurisy. Of course, patients with pulmonary embolus are going to present with shortness of breath. They are also going to have tachycardia, hypoxia, low blood pressure. They may also show signs of right heart failure. In addition, these patients may present with rales, wheezing, or pleural rub. So these are some of the features which will make you differentiate pulmonary embolus from a case of an acute myocardial infarction or an aortic dissection. By watching this video a couple of times, you should be able to memorize or internalize the clinical presentations of each one of these acute thoracic emergencies. So when you are faced with these types of questions, you should be immediately able to pick the answer without reading the rest of the story. I mean, you should read the entire question. Don't get me wrong. Total collapse of the left lung and the entire chest cavity, the pleural space is filled with air, and here's a chest x-ray showing clear space here, and here's a collapsed left lung. Generally, pneumothorax is more often seen in younger individuals. It comes on suddenly. It is associated with shallow respirations. They can also present with difficulty in moving. They can have tachycardia, tachypnea, and hypotension. They can also have hypoxia due to reduced lung capacity. When you listen to their lungs, that's an important clue. And a simple chest x-ray can diagnose presence of pneumothorax. Pneumothorax is a medical emergency, and this can be easily relieved by just sticking a large bore needle into the pleural space, decompressing the pleural space, allowing the lungs to re-expand. So that is about pneumothorax. There are a few GI conditions that can mimic acute cardiac emergencies, and hence it is very important to know, because we have seen patients with acute gallbladder who present like acute myocardial infarction, or even patients who have acute myocardial infarction may present with lower abdominal pain and may be worked up for a gallbladder, only to find out that when they call a cardiologist for a cardiac clearance, you see these patients have Q waves in the inferior leads, and what we are dealing actually is an acute myocardial infarction in a patient with chronic cholelithiasis or something like that. I mean, it has happened in real practice. That's why I am explaining this with great detail. So whenever you have a patient with right upper quadrant pain and upper abdominal pain, always think about both heart and the abdominal pathology. In most cases, it is the acute gallbladder attack. As you can see, the gallbladder attack can extend from the right side of the upper abdomen all the way into the mid part of the chest, and generally this pain radiates to the right shoulder, where the cardiac pain very rarely ever radiates to the right shoulder. These patients may also have GI symptoms such as nausea, vomiting, bloating, and fever if they have acute cholecystitis. A couple of other GI conditions can produce chest pain mimicking cardiac etiology. That includes acid reflux and hiatal hernia, because they can produce retrosternal pain, a burning sensation that can radiate all the way up and down the chest, and sometimes it can radiate to the back. And because of anxiety, they can develop tachycardia, sweating, palpitation. So we have to take a detailed history about GI symptoms or history of ulcer, hiatal hernia, gallbladder problem, and that might help to reinforce the diagnosis of GI related symptoms mimicking cardiovascular symptoms. So ladies and gentlemen, this is a brief overview of the differential diagnosis of chest pain. And whenever you are presented with a case in an examination, you need to focus on not only the main symptom, which is a pain, the nature of the pain, the duration of the pain, the characteristics of the pain, but most importantly, the associated findings that come along with the pain. Does this patient have a radiation to a certain area? Does the pain go to the back? Is the pain associated with the rhythm problem? Things like that. I am Dr. Nik Nikam, and thank you so much for watching, and we will see you next time. Please do subscribe to our YouTube channel, and if you would like us to produce a video on any other important topic, please leave us some comments below, and we will be happy to do the research and produce an educational video in that particular topic. Thank you again. I am Dr. Nik Nikam.